Today's video is related to the humeral shaft fracture. There are two mechanisms of humeral shaft fracture: the low impact trauma or high impact trauma. Low impact trauma includes the fall with an outstretched hand, elderly people, people with the bone disease, and high force trauma includes direct blows to the arm due to motor vehicle crashes, support activities, work related accidents, and the physical assault. Most commonly fractured humeral site is the middle third. Proximal third humeral fractures involve the surgical neck of the humerus. It usually occurs due to the fall with an outstretched hand, results in impacted fracture. Axillary nerve injury is commonly associated with the proximal third humeral fractures. Axillary nerve injury lead to the weakness of the teres minor deltoid muscle and reduced sensation in the shoulder area. Fractures of the middle third of the humerus involve the transverse and the spiral fractures. Transverse fracture from the direct blow, deltoid pulling the proximal fragment laterally, and the spiral fracture results from the falling on an outstretched hand. Middle third fractures are associated with the radial nerve injury, results in the wrist drop, weakness of the finger extension at the metacarpal or phalangeal joints, inability to extend and abduct the thumb, sensory loss in the dorsal aspect of the forearm 1 to 3 digits lateral and the radial half of the fourth digit. Profunda brachii injury is also associated with the middle third of the humerus fractures, results in the forearm and the hand ischemia. Distal third of the humerus fractures results when the person falls on the flexed elbow. Injury of the median and ulnar nerve are associated with the distal third of the humerus fractures. Median nerve lesions include the weakness of extrinsic lateral hand flexor, thenar muscles, and the lateral two lumbricals. And the sensory changes in the volar portion of the lateral 1 to 3.5 digits, and ulnar nerve injury results in the weakness of the extrinsic medial hand flexors and intrinsic hand muscles, palmaris brevis, lumbricals, hypothenar, and introtia, and the sensory weakness in the volar aspect of the medial 1.5 digits may also occur. Now come to the classification of the humeral shaft fractures. The first classification is the OTA classification or the OA classification, since the humerus is considered as a 1 in OA classification and the shaft is considered as a 2. So when there is a simple fracture, it's considered as A, and when the simple fracture is spiral, it's 1 2 A1, and when there is an oblique 1 2 A2, and when there is a transverse fracture 1 2 A3. Now come to the wedge fractures. The wedge fractures are considered as a B. When there is a spiral wedge, B1. When there is a bending wedge, B2, and when there is a fragment wedge, B3. And the complex fractured is considered as a C. When there is a spiral complex fractures is a C1. When there is a segmental complex fracture is a C2, and when there is an irregular complex fracture, it's a C3. Now come to the Garnavos classification. The humerus fracture can be classified as a proximal, middle, and the distal one. The proximo, middle, and the midodistal. Or it can be classified as the simple transverse, simple spiral, the intermediate, and the complex. Now come to the Mahanese Atamata classification of the distal humerus fracture: the high T, low T, Y, H, medial lambda, lateral lambda. In the high T, the transverse fracture proximal to or at the upper olecranon fossa, and the low T transverse fracture just proximal to trochlea, which is the commonest one. And the Y, the oblique fracture line through the both column with the distal fracture vertical fracture line, and as the trochlea is a free fragment, and in this fracture there is a high risk of the avascular necrosis. And the medial lambda proximal fracture line exists medially, and the lateral lambda the proximal fracture line exists laterally, and the multiplanar the T type with an additional fracture with a coronal plane. Now come to the Mills classification of the single column condyle fracture. The type 1, the lateral trochlear ridge remains intact, and in the type 2 the fracture is through the lateral trochlear ridge. Now come to the Neer's classification. It's for the displaced proximal humeral fracture. The first one is through the anatomical neck, in which the humerus divided into two parts, and the other one is the surgical neck fracture, in which the humeral head is also divided into two parts, and the third one is the fourth, and it's through the greater tuberosity. It has a two type, whether the humerus is fractured into two parts or the three parts. The five is the lesser tuberosity. It can be two part, three part, or the four parts. And the sixth one is the fracture dislocation, in which the humerus can be fractured into three parts, and the anterior posterior fracture. And the patient will present with the pain, extremity weakness, and the physical examination will reveal the swelling, tenderness over the fractured side, skin tinting. Examination of overall limb alignment for the deformity will often present with the shortening of the limb and the inverus. These are the radiographs AP and the lateral view, which is showing the transverse fracture to the proximal part of the humerus. These radiographs are showing the spiral type of fractures in the humeral shaft. These are the two radiographs showing the humerus fracture. The first one is the spiral fracture of the middle shaft of the humerus, and it has a greater risk of injury to the radial nerve. And the second one is showing the distal humerus shaft fracture, and it has a greater risk of injury to the median and the ulnar nerve. Non-operative technique include the immobilization in a cast, and the indications are the criteria for acceptable alignments include the less than 20-degree anterior angulation, less than 30-degree varus or the valga angulation, and the less than 30 degree of rotational malalignment, and the less than 3 centimeter of shortening. And the contraindications include the absolute contraindication when there is a severe soft tissue injury or the bone loss, vascular injury requiring the repair, brachial plexus injury, and the relative constipation includes worsening nerve dysfunction and the radial nerve palsy. Operative management of the humerus fractures involve the external fixation or the ORF. Indications for the external fixation is a high energy complex or the comminuted fracture, the open fracture, significant soft tissue, or the bony defect, floating elbow, hemodynamically unstable polytrauma, concomitant vascular injury. And the approaches include the proximal pin should be anterior lateral surface of the proximal humerus, mini open approach with the dissection down to the bone to mitigate axillary nerve injury. And the distal pin's lateral aspect of the distal fragment requires the mini open approach with the dissection down to the bone to mitigate radial nerve injury. Most distal pin is just proximal to the olecranon fossa. What are the indications for open reduction and internal fixation? The absolute indication includes the open fracture, vascular injury requiring the repair, brachial plexus injury, ipsilateral forearm fracture, floating elbow, compartment syndrome, progressive nerve deficit after the closed manipulation. And the relative indications include the bilateral humerus fracture, polytrauma or associated lower extremity fracture allows the early weight bearing through the humerus, pathological fractures, the bun or the soft tissue injury that precludes the braces, segmental fracture, short oblique or transverse fracture, OTA type 1, intra-articular extension, long oblique proximal humeral shaft fracture, the large body habitus, obesity or the large breast, or radial nerve palsy. Different approaches for the ORIC. The most commonest one is the interior lateral approach. The steps of interior lateral approach includes the incise the skin in line with the interior border of the deltoid muscle from a point midway between its origin and insertion distally to the level of its insertion. Proceed in the line with the lateral border of the bicep muscle to within 7.5 centimeter of the elbow joint as shown in the picture, and divide the superficial and the deep fascia and the ligates the cephalic vein, and the proximal part of the wound retract the deltoid laterally and the bicep medially to expose the shaft of the humerus. Distal to the insertion of the deltoid, expose the brachialis and split it to longitudinal to the bone and the retract it subperiostally. Lateral half to lateral side, medial half to the medial by flexing the elbow to a right angle. Subbrachial approach to the humerus. Simply make a longitudinal incision 1 centimeter posterior to the lateral edge of the muscle, subbrachial muscle. Develop the interval between the bicep brachii muscle and the brachialis muscle, starting in the proximal portion of the wound using the blunt dissection. Stay on the interior surface of the brachialis muscle and once over the medial edge, bluntly dissect the muscle from the interior and the lateral edge of the humerus. The subbrachial approach avoids the splitting of the brachialis muscle, and both radial and the musculocutaneous nerves are protected. Now come to the posterior approach. In the posterior approach, you have to make the straight incision over the interval between the deltoid and the tricep muscle and extend it distally to the deltoid tuberosity. Bluntly develop interval between the lateral head of the tricep and the deltoid. Expose the periosteum of the humerus and insides it longitudinally. Elevate the periosteum medially and the retract it and lateral head of the tricep medially. Continue subperiosteal elevation of the tricep proximally until its origin from the proximal humerus is reached. Elevate the periosteum laterally, retract it and deltoid laterally. To extend the exposure proximally, continue subperiosteal dissection to the proximal origin of the lateral head of the tricep and protect the axillary nerve and the posterior circumflex humeral artery at the proximal edge of the exposure. To extend the exposure distally, partially release the insertion of the deltoid muscle and avoiding the radial nerve because radial nerve is beneath the lateral border of the tricep. Now come to the posterior lateral approach to distal humerus fracture. Make a longitudinal incision 15 to 18 centimeter length over the posterior lateral aspect of the arm. Extend it distally midway between the lateral epicondyle of the humerus and the tip of the olecranon, 4 centimeter distal to elbow joint. Proximal portion of the incision must be located 4 centimeter posterior lateral intermuscular septum. From midway of wound, dissect laterally until the lateral intermuscular septum is reached. Incise the tricep fascia longitudinally few millimeters posterior to the intermuscular septum and carefully separates the tricep from the intermuscular septum distally to proximally. Distally incise the fascia at the lateral edge of the enconius, 4 to 4 centimeter distal to lateral epicondyle. Retract enconius and the fascia in longitudinally to tricep. Identify and protect the posterior antebrachial cutaneous nerve as it leaves the posterior compartment at the lateral edge of the intramuscular septum. Retract the radial nerve interiorly. Retract the tricep muscle medially to expose the posterior humeral shaft. To close the wound, allow the tricep to fall interiorly into its bed. Loosely close fascia with the intraoptic suture. So this is a picture showing the steps of the posterior lateral approach to the distal humerus. Now come to the last operative technique, intermedullary nailing. It can be done integrate or the retrograde. Integrate can be performed in a supine position, 3 centimeter incision over the interior lateral edge of the acromion down to the deltoid, which then split to identify the rotator cuff entry site for the nail through the supraspinatus fiber as medial as possible to apex of the humeral head. And the retrograde approach performed prone or lateral can be performed in a prone or a lateral position through the posterior incision over the posterior supracondylar cortex. Avoid reaming across the fracture site to prevent the radial nerve injury.